Good evening to everyone. We are here now to talk a little bit about serration remodeling therapy. And the title of our webinar is called Breaking the Balloon Barrier. But really the main thing is we've got a couple of really excellent practitioners, Dr. Vincent DiGiovanni and Dr. Jeff Silpe, and they're going to share some cases. This is always the fun part. Um, and just talk over this next hour about cases and also about serration and how it might fit in and how this concept of remodeling therapy might make a difference in our practices. So I'm just going to take the privilege of the floor for just a couple of minutes and remind us all about some different things related to mechanism of action and data so far. And this what makes a Serenator different than other technologies. And you can see these ideas here, improving blood flow by reducing recoil, having a lower residual stenosis at the end of the case so that you can optimize wound healing, interrupting the internal elastic lamina, maybe so you can have a better drug uptake. And so the concept is by creating serrations, we provide this release, if you will, or a segment along the artery where the internal elastic lamina has been interrupted, and so that even a low pressure inflation allows pressure to be transmitted along that line so that the artery opens in a more uniform manner. And what we found in our studies, and I will summarize them for you, but the reduction of recoil, the maximization of lumen gain, and these things relate to improved flow and hopefully improved drug uptake. So what could this mean for your practice and your patients? Um, the let's see, there we go. So healing that lasts via serration remodeling therapy. So here's a case. This isn't my case, but I just wanted to show you what what these tibial lesions look like, and you can see what it looks like after Serenator. Both anterior tibial and peroneal look terrific, and here's a wound healing slowly, but eventually does heal. And this is a case from Dr. Gandhi, Sagar Gandhi, that was previously published. But I like this case because it's a two vessel tibial disease, because it's relatively long segment, because one of them's an occlusion, and they look terrific afterward. The serration angioplasty balloon, there are really two, the Serenator and then the SL, what we call the SL Pro. And I'll show you the SKUs for that. It'll make more sense. But this has a serrated element. In the Serenator, there are three serrated elements on the outside of the balloon. And of course, these serrated elements are protected by a layer, and there's a bit of proprietary things that go into this that make this a nicely functional device. And here's the SKUs. So you can see the Serenator goes from 2.5 to 8 millimeters in diameter. It's either 0.14 or 0.18 guide wires. And we have lengths up to 120 millimeters. The SL Pro is really intended for a very small vessel. It's down to 2 strips, but the balloon diameters are 2 and they go in lengths up to 120. And this works great for inframalleolar angioplasty. We've already had, even though it's relatively new or a newer offering, we've had a bunch of great cases. So back to the value, what can a Serenator or serration remodeling therapy do for you or do for your patients? So I'll show you the data, but optimizing lumen gain, mitigating recoil, and minimizing a dissection. And here are the serrated elements progressing into the artery, interrupting the internal elastic lamina, creating cracks, and causing an interruption, or that is cracks in the plaque that allow it to be compressed and allow the artery to open along the line that I mentioned, a line of release. And here are some of the publications, Prelude, both the First in Human and Prelude BTK. You can see the excellent results. I'll go over a little bit some of these, but we also did an analysis. I use the term we broadly. It was really Marianne Brodman's lab, who you know is a real KOL in the EU and internationally. And they looked at the best they could get at a POBA in their lab and compared that with Serinator, and they found that the residual stenosis with Serinator, this is BTK, was 17%, and after POBA was 34%. That was core lab adjudicated. And then the recoil study, and I'm going to go into that. I think that's particularly exciting. And then the pedal artery study. So here's the Serinator, both above the knee and below the knee. You can see what the residual stenoses look like and the maximum uh, atmospheres of pressure required, the low stent rate, and the excellent CDTLR rates that followed. And here's that study from Marianne Brodman's lab where they looked at POBA versus Serinator, found a substantial decrease in final residual stenosis. And this is, I think, just a sign that plain balloons are not going to be adequate for tibial vessel revascularization going forward. And part of the challenge is, and this has been shown in almost all core lab adjudicated studies of plain balloon in the tibials, and that is that the final residual stenosis is very typically around 30% or more. And the Serinator, with the Serinator in Marianne's lab, it was down to 17%. And in another study, it was also right around 20%. So, and here's the recoil study. So this was Vinita Chandra and Michael Lichtenberg. Now, what they did was they reproduced the so-called Baumann protocol. So Baumann published a fairly important paper. It was limited to only 30 cases, but this was back in 2014. They did angioplasty and then waited 15 minutes and did a repeat angiogram. So after the completion angio, they waited 15 minutes, so T0 versus T15. And what he found was 97% of the patients had recoil of 10% or greater. So we wanted to take a look at this again, but we didn't want to use POBA from 2014. We wanted to use modern POBA. And so we did, and using modern POBA. So what I mean by that is a single balloon that covers the whole lesion, a slow inflation, maintaining inflation for a minimum of 3 minutes, modern tibial angioplasty. And with that, POBA had a recoil at T15 or by waiting 15 minutes later of 55% of the patients had recoil. So this is far reduced from what Baumann had published of 97%. But again, this is using modern balloon angioplasty protocol. With the Serinator, 6% of the patients had a recoil of greater than 10%. And so you can see that relative difference. Of course, in a small, slow flow artery like a tibial, a 10 or 20% recoil could make a huge difference in terms of flow, since flow is proportional to the radius to the fourth power. So let me just show this for a moment. It's kind of a dramatization of what we were talking about. So you've got the issue of residual stenosis, which is reduced with Serinator. And then you've got recoil on top of that. So you get the idea that this combination of residual stenosis and recoil is probably why it's not that uncommon for a tibial angioplasty patient to come back early, sometimes at 1 month or 3 months with an occlusion or with a tibial that looks like it needs retreatment. I also mentioned that we did have a study done inframalleolar angioplasty. This was headed up by Ted Gifford from Connecticut. He's been a real mover on Serinator technology and started to use it. Now, this was using the standard Serrator. Now we have the SL Pro. So I anticipate that it could be even better, but you can see freedom from CDTLR, 93% at 6 months, no perforations, minimal bailout, and good wound healing. So this serration remodeling therapy is really designed to be versatile. So, for example, below the knee, 80% of the time it's used as definitive therapy. And here's just a little quote from Dr. Gande, whose case I showed previously, who really appreciates the fact that it minimizes reintervention, again, because of these factors I mentioned. Above the knee, 70% of the time, Serrator's being used prior to DCB, and it makes sense. We have some preclinical data showing enhanced drug uptake, and this combination of interruption of internal elastic lamina plus a better angioplasty result overall is excellent for DCB, where you're trying to minimize the amount of stent placement, and of course AV fistulas. And when Serrator's been used, it's definitive therapy 70% of the time. So many benefits that I mentioned up front. And just to conclude there, as I mentioned, we have two real pros here, Dr. Vince DiGiovanni and Dr. Brian Silpe, both of whom are on the call. And I think what we'll do then is, why don't we go to Vince's slides first? I'm going to stop sharing so that that Vince can do that. And while you're sharing your slides, I'll just mention that he's a vascular surgeon at Mainline Health in the Philly area. He's a well-known specialist in that area and, of course, a larger geographic area in addition. And I've actually got to visit him at his hospital, and that was a lot of fun. So, Vince, take it away.
Thanks a lot, Peter. I really appreciate you having me on to talk about this tech. It's something that's near and dear to my heart and also my partners. I'd like to also thank Jeff Silpe. Thanks for allowing me to present alongside you. I have some interesting cases that I'd like to really share with the audience. And I thought that not just to kind of drill down into the tibial work, which is where we've been obviously focusing with Serration technology for a while. And I can also kind of echo a lot of the sentiments that you made in regards to the absence or the significant decrease in recoil that you have associated with treatment down there, but also the reduction in overall flow limiting dissections. In our facilities, we really have no bailout conduit. It's really, it's a coronary stent in the tibial vessels if everything goes haywire, which obviously is something that would be absolute last resort. But I can say that I confidently use Serrator in single tibial vessel runoff very frequently, and it allows me to be very aggressive, particularly when used in conjunction with IVUS. So you really get a very, very good size match with the balloon and the lumen of the vessel. And I, as of yet, have never had to use a coronary stent in the tibial vessels. But I wanted to illustrate some cases. One is going to be a tibial, and then the other is actually kind of, I guess, maybe relatively novel uses of Serration technology. So without further ado, let me see if I can move forward here. So hope everybody can see my slides all right. So this is actually my first Serration case that I did. Josh Hassinger is our rep, and Josh and I have gone back a long time. And when he first came to us with this tech, I was really interested. And we put it through its paces almost immediately. This was a patient who came to us that had a significant amount of hindfoot disease, multiple areas of ulcerations, and very adequate inflow. There really wasn't any problems with the femoral popliteal segment whatsoever, but was having a really difficult time addressing this hindfoot. I should probably also remark, this was a couple of years ago. So really it was before we were doing, I guess, if you will, like advanced tibial work, the pedal loops, DVA, stuff like that. And it was, tibial was, I guess, in a lot of regards, kind of this great unknown. What happens to the vessels after you balloon them? What happens if you get a flow limiting dissection? So I very much was looking at cases like this with a lot of trepidation. But as you can see, there was diffuse tibial disease here. Both the tibial perineal trunk and the proximal posterior tibial vessels were heavily diseased. Um, and I believe we did IVUS with this, and we elected to treat. We did 2.5 for the proximal posterior tibial and 3.04 by 40 for the tibial perineal trunk. And I hope you can see my results slides. But this was after our prolonged inflation, and we had an excellent result going down to the hind foot. And actually, I think with that we kind of left it. We said, all right, that's enough. I felt like, well, I was dancing a little bit with the devil with doing 2 balloon inflations inside the tibial vessels. But now that I've gotten obviously more comfortable with the tech, I wouldn't have left behind that perineal lesion. But, such was the case. It was going nice and easy early on.
The
Um,
post tib and the TP trunk look great.
yeah, amazing, amazing. No flow limiting dissection. I mean, it looks like it looks like the adjacent vessel, perfectly. So it was really, really, I was very impressed with the technology. And then we were off and running after this. Um, my second case I'd like to illustrate is something we've been doing a lot of lately, which is PTAB detour procedure. We've been finding its utility not just with claudicants, but also with critical limb ischemia, and in particular, people who've had obviously multiple interventions in the femoral popliteal segment. The overall challenge associated with this tech, at least as far as I'm concerned, is really kind of maturing the fistulas, both proximally and distally. And particularly if you've got a very heavily calcified, aortoiliac segment, where you're going to be running into a lot of twists and turns with the devices as you're advancing these torus stent grafts down distally into the distal circulation. You're asking a lot of that material to kind of advance down and drive through. And if your fistulas aren't really matured very, very well, you're going to run into a lot of problems. So we started early on with actually using the Serenator balloon for maturing our fistulas, particularly with somebody heavily calcified or somebody's had multiple interventions in their femoral popliteal segment, such as this person did. People who are familiar with the procedure will kind of recognize this. You get an 8 French sheath up and over the top of everything. You kind of get through your proximal arterial fistula into the venous segment, and then you drive down into your distal endpoint. Excuse me, your distal reconstituted, planned reconstituted area. You get your endocross needle, and you kind of advance everything through. And as you are advancing as you're place your wire through your AV fistula proximally, you've obviously got to mature things. And with us, we've always found there's a tremendous amount of recoil, and that's usually almost predictable. This person, although there's not a lot of metal you can appreciate in the femoral segment, had multiple interventions done in the superficial femoral artery. So you know that it's going to be a fibrotic lesion and very, very difficult to cross. So we went directly to Serenator beforehand and used that. As well as we did, as you can see, this last image on the right, we did another a 5x4 Serenator for maturing the fistula. And sometimes it's just a little bit extra lumen that you get with using the Serenator that's enough to allow you to deliver the torus stents, which are very rigid. They're still a generation 1 device. But I sincerely believe we've done a large number of detour cases as of yet, particularly in people who've had multiple interventions in their femoral popliteal segments. And I feel very strongly that there's almost no way we would have delivered the stent successfully and or gotten an adequate enough lumen across that fistula if it wasn't for a Serenator device. So it really has made our lives a lot easier with treating these. This is our final angiogram in a very, very fibrotic lesion, both the proximal fistula and the distal fistula, very well matured. And then for my last
And then,
case,
Vince,
I'm
before
sorry.
you go
Yep.
on, can we ask you? I don't know if Jeff has any questions, but I wanted to just ask about a couple quick things. One is, so did you use the 5 diameter for both proximal and distal
We
in
did.
that case? Is that pretty
We did.
typical for you?
Generally, we use a 4 millimeter lumen balloon. We did in this case because actually we got so much recoil with both using the 4 and then a 5 millimeter POBA. So we elected to go with a bigger Serenator with a lower inflation pressure that was prolonged. So we were able to actually inflate it 4 atmospheres. We left it up for a minute and a half, and it matured the fistula, and we did not have any recoil at all.
Oh, that's great. And then
Yeah.
it looked like that case was a flush occlusion of the SFA. So how do you decide where to do your crossover from artery to vein in that setting? Did you have a little stump there that maybe you had another angle that you could see a stump, or had
Yeah.
just verbalize that for everybody in case people haven't seen or done that.
Yeah, so it's what you really hope for with the P-tab is that you've got a little bit of a nub there that you can kind of work at, and you can get in the subintimal plane because you've got to get a couple of centimeters into that SFA. Because when you cross over and you do your fistula, it should be about 3 to 5 centimeters inside that SFA. So you're leaving enough stent that's in the native SFA because you really want to land that final stent, at the junction of your common femoral artery, really almost encroaching, if you will, on the origin of the profunda. For us, if we can, there are challenging cases. I'm sure everybody's had their own. One of the things that we've elected to do, actually in the past, if we can't get into the nub of the SFA, is we actually will cannulate the occluded SFA a couple of centimeters, into the vessel itself by duplex ultrasound, and run a wire up into the common femoral artery and snare it, and then use that to actually pull the device down into the origin of the SFA, because you've got to get into that. Without it, if you can't do that, you can't do any portion of the procedure at all. So that's the first step in dealing with it. And obviously,
Yeah.
it makes for a long day if you got to do that.
Yeah, that's interesting
Yeah.
and it makes sense. And then when you go, what's been your experience so far with the distal end? So a lot of times, I mean, clearly you want to end this or you want to land this in the above knee pop, and you want to land it where you have a good lumen, but it's not always a soft artery. I mean, if anything, almost always it's a hard, thickened artery that you're landing in. So is that kind of what got you going with the Serenator in that setting of that crossover point?
Yeah, because that's your choke point for the entire anastomosis that you're
Right.
developing, is that distal AV fistula that you have. Without adequate development of it, you can balloon all you want post stent deployment. You're not gonna get the lumen that you need, and that invariably, we're doing a system wide study and review of our cases, and invariably, that seems to be one of the main causative agents for failure with the detour. So it's really imperative that you get as much lumen there as you can.
Yeah, good. Okay. Well, thanks for that. Sorry to interrupt. Why don't you go
Thanks
on
for the
with your next
questions.
case? You bet.
Yeah. Yeah, it's a good discussion. So, in keeping with non-usual areas of treatment with Serenator, I figured we would show this next case, which is an aortic occlusion. Actually, it was supposed to be an iliac occlusion, but interestingly enough, when we got in there, and you could see from your CAT scan images, there was a patent, or supposedly patent, left common and external iliac artery. We actually got in there. This is actually my partner's case, but I can attest to this. We've done many of these cases, very similar. There was a bilateral iliac artery occlusion, and the distal aorta was kind of being kept open by a thread collateral, fortunately. So it's been our practice that we try to almost always treat these endovascularly if it looks like that you've got adequate landscape, arterial landscape. And in this case, really, we did have a good distal aorta. The aorta wasn't really tight, not super heavily calcified, but we knew that we were going to have to do something to modify the calcium at the distal common iliac arteries on both sides. It's been our practice to use IVL, but there are limitations with IVL. Obviously, there's a cost issue. There's obviously a time issue, generator issue. So there's a multitude of things that make it challenging. IVL has the unique advantage of obviously being a very safe method of gaining lumen, without having to go and rip a big balloon in what potentially is a dissected plane or an occluded vessel, up to, 8 to 12 atmospheres. But we've been using Serenation now that we've got the expanded balloon sizes in this exact role. And as you can see, sorry, it came back a little small on this. We used bilateral 8 millimeter balloons in a kissing fashion, both at the bifurcation here after we were able to cross the lumen, as well as in the distal common and external iliac arteries. And it was in prep, obviously, we use the AFX main body graft for coverage in this area. But obviously, really what is paramount again in dealing with these lesions is having adequate luminal gain, because again, you go in there with a stent graft and you've got a lumen that's 3 millimeters in size. Your limb is not going to be long for being open. And you can see this image now on the left hand side. That's our image following our initial 8 millimeter balloon inflation with the serenators. Um, it opened up both sides. There's a big, heavily calcified atheroma in that distal left common. And we elected to place a stent graft, went up as close to the renals as we could. We actually kept the collaterals open, interestingly enough, there. And the patient did great, went home the following day. And I think it's great. I think in terms of consideration of this versus IVL, I think that obviously there's a role for every technology, but I think that that this is, I mean, it offers many of the distinct advantages that IVL does without the obvious increased costs and overall capital purchase. So we love it for this role.
Yeah, yeah. And then on the on the use of AFX for aortobiliac occlusive disease, do you typically, are there certain cases you're looking for that you like to use AFX? Are they the ones with the longer segment of aortic disease, or are they the ones that have the entire common iliacs are diseased, or which way is your practice heading? I guess I should ask because it's a kind of a thing where we don't really have enough studies yet to know, but a lot of people have thought about doing this, and I haven't heard a really good formula for it yet.
I mean, we in our institution, Peter, we're looking at our records right now, our data, and we're going to probably be publishing something in the not too distant future. We've got probably a good 40 or 50 cases that we can look at that we've been using for isolated common occlusive disease when it actually extends into the aorta. I'm sure that everybody's got their own story, their catastrophic story, but I've count on my hand a couple of times that I've had people who have, after I've done bilateral kissing, covered stents, and the distal aorta has either shifted plaque and bled from a gutter leak there, and had to get converted to an AUI emergently or something along those lines. So that's always my biggest fear. So for me, the AFX is kind of the workhorse. I use it when there's a distal aortic occlusion. I use it if there's a common iliac occlusion, if there's heavily calcified disease where I know I'm going to be aggressive with luminal gain. I'm going to use it under almost all those circumstances because
Hmm.
it seals everything. And I know that I'm not going to get a gutter leak.
Yeah, good for you. That's interesting. Hey, let me ask you guys, we have a question from the audience. How did the panel handle the cost/reimbursement roadblock with administration to get final approval to bring in Serenator? Vince, you touched on it a little bit already about Serenator versus IVL. What do you think? And then we'll hear from Jeff.
Yeah, we had a little back and forth with administration. I think once you illustrate to them exactly what the balloon will do, and you're not going to go in there using 3 balloons per case. I mean, you just have to use one balloon, in the tibials to see that its distinct advantage and durability, over just POBA. I mean, we have people that we've done tibial interventions on that are 2 years old that still come in and get surveilled by duplex ultrasound and their lesion has not recurred. So, I mean, I think that speaks volumes to the efficacy of the balloon. And that's what we just kind of illustrated to administration. And I think they understood it.
Yeah, and I think Jeff, you're in another very sophisticated system. up in New York. What did you do, or what they say to you?
Yeah, thanks, Peter. I mean, it's similar to Vince. I think there's a few things that matter, right? One is that you're going to decrease the total number of balloons that you use in any given case. That'll, immediately kind of offset some of the costs of the quote unquote extra balloons that you might need to get the same result as Serenator offers in its first use. Second of all, is you're going to decrease readmission rates and freedom from target lesion reintervention. And that's huge. We know that every time that we reintervene on a lesion, likely we're, burning some of the outflow and may also be unsuccessful at any given time. Amputations cost money, cost hospital systems a lot of money. And so, if you're using technology that ultimately helps prevent amputation, that's another, huge reason. And then lastly, when you talk about, being a subspecialist in limb salvage programs, you want to say to your patients and to the hospital system that you offer something that might be slightly unique and novel in the sense that not everyone has access to it. And if not everyone's using it, but how efficacious it can be, that's an easy sell to the hospital system because you want patients to stay within your hospital system and have the best options offered to them.
Yeah, that makes sense. Shall we go to Jeff's cases now? And maybe Vince, you could stop share and then Jeff can share.
Got it.
While I transition over, I just want to ask Vince actually a question here. When it comes to CTOs, Vince, how do you handle the decision whether you need to pre-dilate versus just go straight to Serenator? It's a question that I had kind of early on in my Serenation journey. I kind of wanted to get your thoughts on it also, to see if you have a particular algorithm that you use, or what makes you decide to either pre-dilate versus just go straight to Serenator.
Well, I mean, that's a good question, Jeff. With the evolution of the device, we've definitely seen significantly improved deliverability. And Peter could attest to all of this. And the new generation devices, they obviously move through the vessel so much easier. Jeff, my feeling is if I can get it, if I feel like, you get that tactile response where you're like, you're crossing multiple lesions and you're like, oh boy, I'm not going to deliver something easy. But there's also times when, you've got a fibrotic lesion, and everything went through the femoral popliteal segment easy, and you're like, okay, I feel like it'll work. Um, Most of the time, I will pre-dill if it's gonna be a tibial vessel. I mostly will usually almost always pre-dill, because usually it's a heavily calcified lesion. So I just kind of use it to just get my lumen and then go from there, just to make life easier. For femoral popliteal segment, for me, if I can get it to go, I'll use that as my standalone device. What about yourself?
Yeah, it's very similar. I think if I'm really struggling to kind of, cross a lesion, if I think that I'm, subintimal rather than intraluminal, those are reasons I'll obviously, pre-dill. I tend to, like yourself, IVUS quite a bit pre and post intervention. And so I usually have a fairly good understanding kind of where my wire is within the vessel, whether it's in the wall or in the lumen itself. If I'm in the
Yeah.
lumen and everything kind of sailed through, I'll just go straight to Serenator, kind of independent of what level I'm treating. But like you pointed out, if it's a difficult lesion to cross, heavily calcified lesion, I'm in the subintimal plane, really struggled to cross, that's when I'll go, to a pre-dill first.
Yeah.
Or
All
if
right.
it's, I think for me, I agree with everything you said, and I would just add that if you have a long occlusion of the AT, and especially if it starts near the origin of the AT, and you're going to have to do two 90-degree turns early in the course through the occlusion, I'll predilate that. But besides that, I think you're right. Vince mentioned that the technology, the backbone of it has been modified, over time, and I think it's passable on most lesions. I think the times we've needed to predilate has decreased, but nevertheless, it's I think there are things you look out for, like we mentioned. So, anyways, Jeff, why don't you go ahead? So Jeff is a assistant professor, as you can see here, and associate program director at Northwell. So, and again, that's another like the mainline system. It's another big hospital system in New York versus PA. So, take it away, Jeff.
Yeah, and thanks again, Peter and Cajun, for having me. And Vince, it's a pleasure to be able to discuss these cases alongside you. So, thanks for the robust discussion up until this point, and hopefully we can continue. So, this is a 68-year-old male who presented with a left third toe ulcer, probes of bone, and also this kind of plantar third and fourth digit submet superficial ulceration. History of diabetes, heart failure with reduced ejection fraction, hyperlipidemia, hypertension. And, this was his initial angiogram. So a focal occlusion of the AT, occluded perineal and diffuse disease throughout the PT. And, you can see the foot appears kind of underfilled. There's some flow into the DP, and some very little flow into the posterior aspect of the foot. And my kind of goals going through this case were primarily that I had to get enough flow to the digit to treat that in terms of an angiosome. But the plantar aspect bothered me also because this is a third fourth submet ulceration. If he had osteo there, or if this ends up getting worse, then he's going to need some type of posterior, reperfusion or perfusion here, in order to heal potentially and eventually a TMA. And so, kind of targeting both AT and PT here. As I pointed out, typically perform IVUS. So I take several measurements of the normal vessel, of what normal, quote unquote, normal vessel I can find. Here it measured about 2.8 millimeters in diameter. And so I used a 3 millimeter serrator, and I treated the AT. This is the AT. So I treated the AT first, and had a really nice result. And this is actually the video of the post-intervention IVUS through the AT. And you can see all the things that we've talked about: consistent, precise luminal gain. Actually, if you look fairly closely in some of the calcified portions, you can see some of that scoring. I'm just going to play through that one more time if I can. And this is once again a very low pressure system with minimal recoil, and preservation of the luminal gain, which, as anyone who treats infrainguinal arteries knows, that luminal gain is the name of the game. And we had a really nice result here. Um,
It looks great.
Thanks, Peter. Yeah, I think we were very happy with the AT. This was our, kind of runoff from the AT now. There's better filling through the DP and into the digits. And once again, that posterior portion was still bothering me because I wanted to make sure that we were really getting enough flow to the plantar surface of the foot too, especially if we ever had to bring up a plantar flap. And so I used the 2.5. This, I didn't show the whole IVUS here, but we did IVUS that as well. We used the 2.5 millimeter Serenator here by 150 with two tandem inflations. And, once again, we basically treated the diffuse disease throughout the PT. And now we have filling through both the anterior tibial and posterior tibial. And if you notice that there's towards the end of this angio, there's a blush on the plantar surface of the foot. This is a single inflation with every balloon that we used. Standard on IFU inflations, up to 6 atmospheres total, with both the AT and the PT. And I was really happy with what we ended up with here. He went on to have a third and fourth ray resection. They at this point did not have to take any more of the metatarsal heads back. So hopefully for now he's going to do okay without a TMA. But at least we
It's
know that
beautiful,
the
beautiful
surface is
result.
there.
That's
Thanks so much.
gorgeous.
Appreciate it.
And Jeff, could you just tell the audience and tell for Vince and me kind of how what your thought process is on when you use IVUS for tibials and when you feel like it's probably not necessary? I mean, obviously this is a topic of discussion right now. There's probably no absolutely right or wrong answer, but I'm always interested to know what people are doing. It's seems to be evolving as we speak.
Yeah, personally, I tend to use IVUS in majority of my cases. And I think the reason for that is because I think we underestimate the size of the tibial vessel on angiography. And therefore, I feel like at sometimes we undersize our balloons and don't achieve as much luminal gain as we have potential to achieve if we have a more accurate measurement. And I feel that IBIS gives us that most accurate measurement, especially in some of the more complex and longer lesions where there might be mixed morphology. There might be some areas that are occluded, some areas that are high grade stenosis. But in general, I think it gives you the most bang for your buck. It adds 5, 10 minutes to the procedure, and it just gives you more data. So I would say I'm about 75% of cases where I'm using this, unless I'm treating like a short focal, non-complicated, heavily calcified lesion, where I kind of know, exactly what the normal looks like and what I'm going in to do. But if it's anything more complex than that, I really tend to use IVIS both pre and post to make sure that not only I'm sizing appropriately with my intervention, but that we have achieved the result that we want.
Yeah. And then before we go to your next case, can I ask you guys a couple questions?
Sure.
We have some questions from the group out there. One is about the use of drug-coated balloons, and I think it's from Joseph, and I think the general gist of the question is, are DCBs like a go-to for you? And obviously, we don't have tibial DCBs, so must really be thinking of SFA, FemPop. Where does DCB land for you guys right now in terms of your priority of usage?
For me, I use DCB whenever I can. I think it leads to a more durable intervention, especially in combination with Serenator technology. It works really, really well. Um, Serenation, technology, as you pointed out, when you were talking, Peter, kind of creates these cracks or scores in the plaque in the wall of the artery. And that allows you to deliver drug deeper into the wall of the artery, which I have to believe decreases inflammation, improves durability of your intervention. So I use it quite often in the FemPop space.
Yeah. Yeah.
Yeah.
How about you, Vince?
Yeah, I agree. I mean, we almost every lesion that we address is treated with some type of drug therapy. And I can only speak anecdotally. We haven't really drilled down on our data, but I know that our patency rates, particularly with regards to, high grade stenoses, is definitely it's markedly improved. I think, the question is still out there. Well, what do you do with long segment CTOs? What's the ideal treatment? There's some data that suggests that drug coated therapy with in conjunction with placing a scaffolding is beneficial, and we kind of follow that algorithm. But they're a little bit of a wild card. It doesn't take much of a compromise of your lumen or someone coming off their meds or something like that in order to kind of re-occlude a long segment occlusion. But we try to use therapy as much as possible.
Yeah. And I think one thing I did leave out was the use of drug um, coated resorbable scaffolds or DRS. Now that we have a bioresorbable scaffold for below the knee, and my impression is that the better you prep, the better that device works. And I think Serenator is great prep for below the knee bioabsorbable scaffolds. But I don't know, do you guys have any experience with that yet?
Yeah, it sounds like similar to Vince. We use them quite often in our practice, mostly reserved for longer CTOs and the tibials. And we've had tremendous success using Serenator into a bioabsorbable scaffold. I think they work well. I think, like Vince pointed out, drug elution, when you can use it, should be used. As you pointed out, Peter, I have no data to kind of back that up yet. But kind of speaking anecdotally as well, we've seen tremendous success with that.
Yeah,
Yeah.
and I think for me, DCB it still remains first choice for SFA lesions. Initially I had to look for a reason to use it. Now I feel like I need to look for a reason not to use it. But it's still an evolving story. We have a lot of experience with paclitaxel now, and of course, we're going to hear a lot more about sirolimus in the coming years, so we'll see. Anyways, then I know Jeff, you got another case, but before you do, let me just ask one more quick question. We got a couple of different questions that are really similar. Um, and they have to do with what's the best kind of case to do as your initial case or your first few cases with Serenator. Would you go for a FemPop lesion, a calcified above the knee, or I mean, I'm making this up now. There was the initial question was what would you go for? Or would you go for a BTK case, or what do you think about that?
Oh, Vince, you
Well, I
showed
can
your
say
first case, so
I was going to say I could. It's easy for me to answer. I know what endeared me very quickly to this to the technology, and it was a tibial vessel because you don't. I never had such a profound vessel response to really balloon angioplasty. It almost looked like I dropped stents in those tibial vessels, and the plaque morphology was definitely favorable. I'm not going to say that it wasn't, but also I went in, I IVISed it. I knew exactly what size vessel I was going to be approaching, and it was a limb salvage case, so I could stand to be a little bit more aggressive. But after after I had that result, I mean, it was very easy for me to advocate for it. So I would say tibial vessel all day, and I would strongly suggest do IVIS pre and post, as Jeff has mentioned. Know exactly what size you're getting yourself into, and do a low and slow inflation, and I think you're going to have amazing results.
Yeah, good. Yeah, the honestly, the thing that grabbed me early on was that you could see exactly where the balloon was from start to finish. Not just that the lesion was resolved, but areas that you thought were okay, but because they were included in the ballooned segment, it just looked so much more robust after. So yeah, I guess I'd agree. Anyway, Jeff, please go ahead. We keep interrupting
yeah,
your
no, not a problem. This discussion is great.
presentation.
This is what makes this is what makes the webinar. This is what we need. So, this is actually I think a great case to show because it highlights something that I was taught in my fellowship is not the best idea. And so let me elaborate on this. So this is a 69-year-old man with a right lateral plantar heel ulcer, probing to bone with surrounding cellulitis. And he comes in basically, as you can see, with this fairly focal CTO of the behind knee pop. And when I was trained in a fairly open, heavy fellowship still that was pretty reluctant, I would say, to treat behind the knee disease. I think many people are in general, right? We know the popliteal
Yeah.
artery is prone to dissection. We know that if we were to dissect the popliteal artery, things bad happen. And so this was a case where it's the perfect employment of Serenator technology because it allows you to treat behind the knee with a balloon that is made to be inflated at low pressures and helps to mitigate the risk of dissection while maximizing luminal gain and preventing recoil. And so I wanted to just show you what I see in nearly every case that I do in general, but especially in the FemPop region. Um, so this is the Serenator. This was a 5 millimeter Serenator, and I wanted to show you the difference in inflations at 2 atmospheres, 4 atmospheres, and 6 atmospheres. And the reason I want to highlight this is because in nearly every case that I perform, I see full effacement of the balloon at 4 atmospheres. Vince, do you see the same
Yeah,
or
agreed.
close to it?
Agreed. Yeah.
And so I think it's important to highlight this because it really is. It's not just we're telling you it's low pressure. It really is a very low atmospheric pressure that you're inflating these balloons to with full effacement of the balloon. And then, when you go to six, you're getting to your nominal, basically balloon size. And that's the size that you intend to treat the vessel at. And so I think this is important to highlight because it allows you to treat lesions that you might have not been keen on treating before, especially in the behind knee pop, where you are concerned about dissection, because this balloon does help to mitigate the risk of dissection. And this was the result post Serenator on the left side of the screen, and then the right frame shows post DCB. I think there was some movement on the wire there, but in general, really happy with this result. Below this, there was three vessel runoff. It's just not timed properly in this cut. But I was really happy with the result here. We did a DCB. Once again, I inflated the DCB here. It's at probably 6 atmospheres also. So we maintain that low flow. We know DCBs in general just have a little less pressure on the wall of the artery. And so this got me to where I wanted to be. And shows you, highlights the fact that, this is such a versatile balloon. As Vince demonstrated in his cases, showing a wide spectrum of cases. This is just a balloon that can be used everywhere, including on the access side, with good results. And just to re-emphasize something that Vince showed here, I didn't know that you were showing a detour also. But
Great
I
minds
do,
think alike.
yeah, exactly. So I do a large amount of TADVs with LimFlow and PTABs with Detour, and I use Serenator in every TADV case that I perform and every Detour case. And I had done many Detour cases prior to ever using Serenator, and as Vince pointed out, this was a complete game changer. I mean, I achieved like full effacement of the Serenator at 4 atmospheres. I didn't have to worry about retrograde dissection in the SFA back towards the Profunda, which sometimes happens when you have to crank up the other balloon. I didn't have to worry that the fistula or quote unquote anastomosis would recoil before I could reintroduce the stent, as Vince pointed out. And so this has been a game changer in my practice, in terms of using it within both of these kind of other types of procedures, being TADFI and Detour, and I've had tremendous success. And it has decreased the length of the procedure, and improved, I think the luminal gain that I see at both anastomoses and the contour of the stent, which I've been super happy with. So I just wanted to reemphasize that as well, and make it noted that this is becoming a more common thing, and once again just shows the versatility and precision of Serenator as a go-to balloon for first line therapy.
Yeah, terrific. Yeah, I think inflow for DVAs is really nice also. And very often you're stressing and straining to try to get your inflow to your DVA off of a really diseased posterior tib or something like that. And having serration rather than just plain angioplasty is really helpful there. Hey, there's one other question here from the audience about what's been your experience so far on pedal interventions. And I mentioned that Ted Gifford had, put together a series, and I think Mike Watts was in on that, and Mike Sia. And also, like I said, it was put together even before we had SL Pro, and I think that's kind of changed things now with the availability of SL Pro. But how about for you guys? Have you used it in the foot at all, and what's been your experience so far?
We have not used it in the foot for pedal loops yet. We've used it in for malleolar, for lesions pretty far down. But we usually with the pedal loops, we kind of rely on the age old Surmotics devices with the really long delivery conduits. I'm sure that it would cross. The SL Pro drives very very nicely through there, particularly with an antegrade access. But yeah, how about you, Jeff?
Yeah, no, I'm the same. I haven't yet found the right case to use it below the ankle. I've used it basically through the ankle, but not really. I haven't used the SL Pro and I haven't used it much below the ankle. I think that um, it really depends on your practice. For me, I'm kind of like in the field, in the thought process now where I go to DVA fairly quickly. Because it doesn't burn bridges for the most part of your vessels that you're using as your donor arteries. And so, if there's still flow via, one or two vessel runoff into your pedal arteries, it doesn't, burn the bridge of having to go back eventually with SL Pro and treat those arteries in the foot. I just think it brings a lot more flow and is a little bit more durable earlier on, into the foot, and that's kind of what made me go that direction. But I think when I find the right case, SL Pro is going to be a game changer because it's the same technology, it's just made for that space. So I'm looking forward to figuring that out and finding the right case for it.
Are you
Yeah.
saying that you're transit? I apologize, Peter. Like Jeff, are you transitioning away from pedal loop revascularizations when you have it? So you're going deep vein arterialization now earlier on than trying to do multiple pedal loop interventions.
I am, yeah. I mean, I think that, these pedal loop interventions, durability of them is always in question. 3 months, 6 months, maybe you get a year out of it. And there's issues with DVA. I'm not saying that any technology is perfect. I think you, like you said before, you want to have options and you want to be able to, explore every option. For me,
Yeah,
what I've found in my DVA practice is my limb salvage rate at 1 year is over 80%. And I can't argue with those kinds of numbers,
great.
And I think a lot of that is because the architecture and the physiology, the blood flow within the foot changes quite a bit. And even when the DVA goes down eventually, you've still now probably collateralized and opened up dormant arterioles and capillaries that weren't once there. Not to say that pedal loop doesn't have a place. There are patients that don't qualify for DVA or just are not good candidates for it because they might not follow up as often as needed. They might not have the social support system, et cetera, et cetera. And I do think there's definitely a role for below the ankle interventions. And as SL Pro achieves, I think as the technology continues to improve within that space, we're going to see more durable results. And I'm looking forward to that.
Yeah. And I also think, and you kind of touched on this, I think Jeff, maybe it was Jeff that said, kind of through the ankle. Well, we have a lot of patients with tibial disease that doesn't really stop at the ankle, but it goes, maybe you get that chunk of calcium in the common plantar that you've got this beautiful PT emptying into a really terribly diseased common plantar, or maybe you have a nice AT, but then you have that rock hard a stenosis right behind the extensor retinaculum. Those are great for Serenator. And I think now with the SL Pro, actually going around the loop is much more readily achievable. And of course, it's a lower bailout rate. I mean, it's a less chance of an acute occlusion following angioplasty as opposed to plain balloons that just really weren't designed for those kind of focal calcific chunks in small arteries. But anyway, thanks, guys. You answered every question I could think of and every question the audience put out there, and great cases. Really interesting observations. I know it's getting late there on the Eastern time zone, so I'm gonna call up Corey Laytonson now, and Corey is with Silk Road, with Cagent. And sorry, did had some carotid stuff going on today. Anyways, go ahead, Corey. Why don't you finish us up here?
They'd really want you to say Boston now, but
Yeah, yeah, all
well,
that, all that. That's a different
um,
department. Having said that, the case I just came from was a tibial pedal angioplasty using Serenator. It's kind of funny. Anyways, go ahead, Corey.
hey, no, it's a pleasure to be able to just listen to the experiences of this group. On behalf of the Cajun team, just wanted to say thank you for sharing the insights, and for everyone on the line for spending your time with us this evening. Just a terrific discussion, some great cases. Really goes to the heart of I think what we're all trying to do, right? Which is limb salvage, which we know saves lives. So just fantastic discussion, and thank you all for the time this evening. Appreciate it.
All right, so Jeff, Vince, Corey, guess you guys are going to take the rest of the day off, I hope. I'm on the West Coast, so I may have a little more to do, but we'll talk to you guys soon, and thank you so much, huh?
Thanks, Peter. Thanks, Jeff.
Thanks,
Thanks
Thanks,
all.
everyone.
Corey.
Thanks, Vince. Thanks, Peter. Thanks so much, Corey. Take care. Have a good rest of your
Thanks,
night.
Take care,
guys.
guys.